Good afternoon, everyone. My name's JackCote. I'm a research coordinator with the University of Virginia School of Medicine, Department of Neurology. We work pretty much there with telemedicine, and I guess we'll talk a little bit about that. Anybody feeling hypoxic and need to stand up, stretch your legs? Nobody's getting a clot, right? All right. Promise will be high speed, low drag on that. So we'll start talking about a little bit about stroke. About 800,000 Americans every year having a stroke, fourth leading cause of death in the United States. Right now, I think if you talk to my wife, who's an emergency physician, people aren't so much worried about their heart attack anymore. They can put a catheter in me, they can stent it, I'll be fine. But everybody's really scared about having that stroke, becoming paralyzed, and living as a cripple for the rest of their life. So right now, you'll see, it's a fairly frequent event. Every 3 to 4 minutes, someone's dying of a stroke. Different types of stroke, all right? You'll see we have the ischemic strokes. We're having those big clots, sometimes formed by an embolus when you've sat too long, all right? Or sometimes they're hemorrhagic, where you blow out that vessel wall and you really see a lot of damage going on in the brain. If you look in the epidemiology of it, if you see these shaded areas, you'll see that in Southeast America. United States, we have a darker color, far more strokes there. Right there, they've been identified as the stroke belt. Central Virginia to Eastern North Carolina is the buckle of that stroke belt. Here, you get a little bit more detailed information. You can kind of see those colors. You can see where we're at right now. Some folks are having strokes, and I think it's kind of identify these areas where it's kind of rural and not necessarily have great access to hospitals. So, in acute stroke care, time is brain. Very much our mantra here, and we're trying to make things happen quicker. All right? Right now, if you talk about ischemic stroke, the only FDA-approved intervention that's pharmacological is TPA. Dr. Haley at the University of Virginia was one of the principal investigators on the original NINDS trials, and we have those windows of approval for 3 to 4.5 hours. Although beyond 180 minutes, you start seeing the increased risk of symptomatic hemorrhage and decreasing benefit. Okay? If you look nationally, less than 4% of the patients that are suffering ischemic stroke receive TPA. We're trying to address those numbers, if it's clinically effective, to really try to push those lytics and really address those door-to-needle times. If you look at every minute in a large vessel occlusion, what can happen? You're losing almost 2 million neurons. You're losing almost 14 billion synapses, all right? You delay these treatment for these patients, they age almost 4 years in their brain. Again, our treatment windows, in addition to the use of IV TPA, now we're actually starting to see a push for mechanical thrombectomy, the actual puncture of a groin to drive a guide wire up into the brain and actually do clot retrieval. In February of last year, there were a number of trials that were published. They're having new guidelines, and these patients, and if you see them, they're receiving both TPA and then undergoing endovascular therapy. We are actually pursuing this quite aggressively at the University of Virginia. All to pursue the magic of the penumbra. If you don't know, that's the shadow of the moon right there, okay? Within a stroke, the penumbra, the laser pointer's not working right now, is that area surrounding the necrotic tissue in the brain that's already died because it's been deprived of oxygen. And if those vessels can be revascularized and opened, they reperfuse, and the damage to the brain is lessened. So where do we go? We're all EMS types here, so we're going to ride that ambulance. In Virginia, there's the Virginia Stroke System Task Force. It's about partnership, it's about coalition. Every from community education, in-hospital acute care facilities, and of course the EMS community and the pre-hospital providers. The lady there in the red dress, that's one of my bosses, Dr. Nina Solinsky. She's the director of our STAT program, and that's Stroke Telemedicine and Teleeducation. We actually do fixed facility telemedicine with 4 regional hospitals. That's Culpeper, Augusta Health, Bath, and we'll be bringing on Norton Community Hospital in Wise County, Virginia. We've seen over 300, quickly approaching 500 TPA telestroke encounters. And if you see our numbers there, for those patients that are in fact eligible with acute stroke that are seen via telemedicine, we have a 20% rate of TPA administration, so 5 times the national average. Again, if you look at all these door-to-needle times, everything is talking about narrowing these windows and really trying to compress time. And we have seen that in the pre-hospital phase of the patient encounter is the greatest opportunity to find those minutes. In the American Heart Association Target Stroke, they actually noted some key findings, and that noting that people that live in rural areas, they are finding disparate service areas because of their proximity to hospitals, the length of their transport times, some of the variability in training. That's to say, the basic volunteer EMT versus a career professional paramedic. And sometimes, and you're looking at the research now, you'll see that there is debate about the accuracy of the pre-hospital stroke screen that's being employed. And also within this, that pre-notification has actually been shown to show a definite improvement in the in-hospital acute treatment phase. As you cobble this all together with EMS systems, and you'll notice that your EMDs, your telecommunicators at your 911 centers are actually your first point of medical contact. Here, and you've seen that if the telecommunicators can actually use keywords and identify stroke, that we can actually carve about 10 minutes off of a scene to arrival at hospital time. So there's a significant interval there. A little bit of EMS humor for you. Anybody know a telecommunicator or dispatcher? Voicing some of their frustration at the volume of calls that they receive and wondering why folks may have delayed and denied their own symptoms. So if you have that bad headache and you're feeling dizzy, I'm just saying. Again, it's all time dependent and it's all systems driven, all right? And every last one of us is part of that system, from being the patient yourself and understanding that you're having symptoms and not being in denial, to actually making that call, to seeing the medics arrive on the bus and taking care of those folks, to making those critical connections back to the acute care team in the hospital so that they can make the clinical decisions to treat, push those drugs, and then follow them in an intensive care setting for hopefully a positive disposition. Target stroke 11, they did notice 11 best practices here. You'll see number 1, EMS pre-notification. All right, everything else comes up to be in hospital and part of the acute care phase. But number 1 being EMS pre-notification, really seeking to narrow those windows in treatment. This is the program that I'm part of. I treat, improving treatment through rapid evaluation of that acute stroke, and we're using mobile telemedicine. All right, we built this kind of on a STEMI and trauma systems model because those are time-dependent disease states. All right. We are really seeking to take advantage of and have that early notification of the receiving emergency department, all in an attempt to narrow those door to CD intervals, and then after CT, a door to needle time. Here's our intrepid leader, Dr. Andy Sutherland. He's one of the vascular neurologists at UVA Department of Neurology. He really has embraced the technology in both on our fixed facilities STAT program and trying to take this forward into the pre-hospital environment and make this stuff mobile. You'll see here, this is Jason Lippmann. He's a graduating 4th-year medical student at UVA, and Kim, one of our Medic 5 staff members. Jason was part of our project, and he actually did a technological feasibility study, and he published this. And you'll notice that we use real-time mobile video. We use 4G LTE cellular. We partner very much with Verizon in this because Verizon is the #1 provider of cell service where we're at in Central Virginia. Within Jason's project, we had more than 50 test runs. We had good interclass data acceptance there. And if you see now, we actually have gone to a phase 2 study where we're enrolling live patients. We have 5 partners. That's Fluvanna County Rescue, Greene County Rescue Squad, Louisa Fire Rescue, and West Albemarle Rescue Squad. 3 of those agencies, Fluvanna, Greene, and one of our others, Buckingham County, are all staffed by the Medic 5 folks at UVA. So it's kind of been an easy partnership there. Here's connectivity mapping. Again, like I said, we partnered with Verizon. The darker shades of red means higher levels of connectivity, denser tower states. And if you see that and compare it to the map below it, you'll see that it's a 29 north and south, 250 east and west, and a 64 east and west. Those are the primary transport corridors for our EMS partners. And we noticed that we had strong connectivity, so that we realized we had the opportunity to leverage mobile telemedicine there. And the targeting of our agencies, we have another large county agency, Albemarle County Fire Rescue, and of course they run higher volumes of calls, but their proximity to receiving ED is such that we would not have time to actually have a mobile telemedicine encounter and do a full NIH stroke scale evaluation of these patients. The agencies we've chosen have at least 15 minutes of transport time. Some of them as much as 30 to 40 minutes of transport time. So we have the opportunity for them to render patient care, contact our docs, and interact with them over these platforms. We started here with our enrollment criteria. We started really unambitiously. We tried to take it easy on the manpower. We said Monday to Friday, 8 to 5, and you had to be Cincinnati positive to get into our study. All right, so again, the facial droop, the arm drift, if you had slurred speech, and you had to have stroke symptoms for less than 24 hours. We saw very low enrollment, and we were wondering, how do we get these? We really need to get our numbers up. And in our initial assessment of some of the data out there, we knew that stroke was about 3% of the total EMS call volume in what we call the Thomas Jefferson EMS region, which is about a 5-county region in Central Virginia. And so we knew that they were happening with some frequency. We just needed to figure out how we broadened our net and how we increase our enrollment. That being the case, we decided to modify our enrollment criteria, and the IRB agreed with us. To do that, we said, last seen well. Not a big thing. We're still going to keep them at 24 hours. If they're 18 and they speak English, they can be in our study. What's the dispatch information? If it went out as a stroke, if our EMDs thought it was a stroke and they punched it out to these guys as a stroke, they could qualify and be in. No longer did they have to have witness symptoms and things of that nature. We're not so much worried if they're on Coumadin, on Eliquis, or any of these other new age anticoagulants. If they are experiencing any kind of neurologic symptoms, we're willing to talk to these patients. If there was any kind of history of stroke or TIA in their medical background, we're willing to talk to these patients. And then in doing this with increasing numbers, we've taken also the 8 to 5 out. We're now 24/7. Everybody's been supporting it. Our MedCom folks, who are actively our activation linchpin, have been supporting this, and we're actually seeing our numbers increase. So a broadened net, widened catchment area. You look here, this is some of the pictures of what we're actually using. We're calling it a tablet-based system, but we're using an iPad too. And if you see it, a firefighter and a paramedic can break anything. It's true. So we took a very delicate iPad too. We put it in an OtterBox. It's held up to the challenge so far. We've actually gone so far as to drop them on the floor to prove it to them. We use a ram mount suction block and cradle mount, and we're sticking it up in the ambulance in a vertical or horizontal sense. And the guy said, "What happens if I leave it on the door and I slam it?" And I said, "Well, put it up there and try it." And so we stuck it to a window, and he slammed the door, and the mount stayed. The iPad went flying through the back of the ambulance. So I said, well, maybe we don't need to slam the doors. And these guys have been great, and they've been innovators. They've really brought a lot of thought back to us, and they've helped us refine the system, because this was not the original live system that went out there to them. The first one we took was a big adjustable arm wire clamp thing, and they said, no, we don't like it, we're not going to use it. So we came back to them with this change. We took all this gear, we crammed it into a 1500 series Pelican case, all right? You'll see all of it in there. What's that there? There it is. Okay. This is a Cradlepoint IBR600 modem. It has antennas that are both LTE and Wi-Fi. So it's making multiple connections to multiple LTE towers as it bounces down the highway, and it creates a Wi-Fi environment of roughly 60-foot radius around the bus itself. You'll see we included in this one a UPS, but we're finding that with each individual ambulance, you almost had to customize the solution every single time. We actually had one of the buses that did not have an inverter. So it wasn't, even when the truck was on shore power, it wasn't charging the UPS, and the UPS eventually failed. And that corruption of power actually kept the modem from being able to boot successfully. And when our guys went out there and they had a potential patient, the iPad was dead, the modem wouldn't connect, and we had issues, and we had to go back and do a lot of mitigation with those folks. And that being the case, we actually pulled that UPS. And in another case, we burned up a 12-volt inverter, but those guys seem to like that one. So we're using that over in Fluvanna County, and it's being quite successful. If you look at it when it's fired up, we're using Jabber Video. It's a Cisco application. It's been deemed to be HIPAA compliant, both on the security and privacy side, okay? We take all the icons and we squeeze them all away and we put them in a folder, so all they have up there is settings and Jabber. All right, so we tried to take this to a point where we knew we had to be hands-free. We couldn't turn the paramedics into cameramen, right? They needed to be able to be mobile and to assist us with the exam. And so all they have to do, deploy the equipment, turn on the iPad, launch the app, wait for the call. And that's pretty much all they have to do. And they've been really pretty great about doing their own troubleshooting when it comes to sound or power or connecting to their modem. If you look at it here, this is one of the Greene County ambulances, and you can see Dr. Sutherland in the iPad screen. We had some folks say, well, why don't you just use a smartphone? You can just use a smartphone. It'll work just as well with a smartphone. We were very insistent that we created a genuine telepresence of the physician in the back of an ambulance. And a 3-inch picture of a doc is just not quite enough. When you actually have that face there, it really seems to actually have that presence in the back of the bus. And if you look at it some more, we'd originally targeted the back windows, but anywhere in this whole 90-degree angle, if it's smooth, clean, and dry, they can use this suction mount and it attaches. And if you see it here, it's actually attached in an upside-down inverted vertical state. So what do we need our EMTs to do out there? Within the NIH stroke scale, there are several elements. What we need them to do is help us judge eye movement. Can you follow my finger? You know, how many fingers do you see? One finger here, or is it 2 fingers on the left? What do you tell me? Sometimes they have to raise or lower an extremity and answer a physician's question. You know, did they just drop their arm, or did you just hit a bump in the road? Things like that. Can you reach out, finger to nose testing? Soft, sharp, left or right, tell me what you're feeling. And then we actually, within the stroke scale, they have some cards that they have to read. Some of the things that our folks in the field ask us, all right? Can the neurologist give me orders? Absolutely not. They're there as a consultant only. If you need medical control orders, you must call your regular ED attendings and get orders from them, all right? And then we also tell them patient care remains your priority. Don't do anything that's going to put your patient, your crew, or your bus at risk, okay? If they're hemodynamically unstable, they comp their airway, forget the study, take care of your patient, follow your protocols, transport your patient. Some acknowledgments, our stroke team, all of our docs back there, some of our partners in emergency medicine, Verizon, Cisco, and the UVA Center for Telehealth.